We are live, sir.
Right.
Thank you everyone for joining us on a Sunday morning for our latest edition of Practo Connect webinar. My name is Dr. Nilesh Bhandari and I head Doctor Relations at Practo. Today is our 25th webinar and we are going to be speaking on technologies transforming cardiac care. So we have seen in the last 25 to 30 years at least, if not since 40 years, a lot of technology coming into healthcare, and we have new devices, new techniques, new drugs, new vaccines, stem cell therapies, everything making a huge difference in patient outcomes in various specialties and especially in cardiology. To speak with us on the top technological changes which have affected cardiac care, we have with us Dr. Colonel Anil Dhall, sir. Welcome, sir.
Thank you, Nilesh. Great to be here.
So, Dr. Anil Dhall, sir, Sena Medal, was our faculty in Armed Forces Medical College. Presently, he is the head of department at Janakpuri Super Speciality Hospital in Delhi. He's earlier been in a number of hospitals, including Sarvodaya Hospital and others like Max Devi Heart and many others. He's a MD medicine with the DM in cardiology and has special interest in complex coronary interventions, peripheral interventions, angioplasty, endovascular aortic aneurysm repairs, and other therapies. One important point was that he started the first cardiac catheterization lab of the Army Hospital in Delhi Camp, and that's a huge task, sir. Congratulations once again on that task.
Well, that was a long time ago, Nilesh. They have done very well after I have gone from there. So
that's great to know, sir. So, sir, I would like to hand it over to you to take it forward from here and tell us more about this.
All right. Thank you, Nilesh. It's great to be here. And thank you for this opportunity and great to connect with people on a Sunday morning. I do not know how the spouses are permitted their bitter halves to be made available on the first half of a Sunday morning. Normally, there are many household chores to be done, rounds to be completed, so on and so forth. But Nilesh felt this was the best time that we could steal you away for this kind of interaction. So may I share my screen if you permit, Nilesh?
Please, sir.
All right. So I will just put together. So Nilesh asked me to speak on emerging technologies in cardiology. Now, this has been a process which is very dynamic, and it is also a process wherein we are learning every day, and truly we are nothing more than spectators as well as to some extent mild participants and students of this very, very exciting journey which is happening. As we all know that in the last few years, technology appears to have kind of outpaced itself. And we are today, all of us are slaves to our phones, we are slaves to our computers. The meetings are no longer having to undertake travels, and you can do things, a lot of things digitally. So I'm going to be in this series discussing a few game changers. And the heart of this game changer is going to be where we have new drugs, where we have new devices, where we have new approaches, where we have new exciting developments which are going to take us to where we want to do the best for our patients. Because ultimately, as a physician, our responsibility is to the patient, his community, the whole community, and greater human good. So, like we said, it all starts with prevention, because an ounce of prevention is better than a pound of cure. So we're going to start with a little bit about Cvd prevention, where a lot of exciting developments have happened in lipidology. There are stupendous developments in diabetology. We have almost completely changed our practice of diabetes. And why is diabetes here? Because 80% of diabetics will succumb to cardiovascular disease. So we teach our students that diabetes is indeed a cardiovascular disease. Hypertension treatment has become so easy. And today we have opportunities by which we can not just improve the ability to treat high blood pressure, but also to do it seamlessly, because maybe a couple of decades ago, the treatment was sometimes seen to be worse than the disease itself. We have a complete revolution happening in the space of pharmaceutical therapy for obesity. Believe me, this is one of the most exciting areas in the last few years. And we know that it all moved from our understanding of SGLT2 inhibition, GLP-1 receptor analog, which are being used. And now we have dual agonists. And now we are moving towards triple agonists, which are going to give you about 20-25% weight loss, which is like wishful thinking. Interventional cardiology is the most introspective branch, the most studied branch, the most accused branch of medicine, because everything that we do can. Just before this call, I was speaking to a colleague in Chandigarh because one of our urologists had an MI at 2 a.m. His arteries were open, but he had an out-of-hospital cardiac arrest, and he's on high inotropes. So those things don't change because cardiology and coronary artery disease can kill. But the way we are approaching coronary artery disease, the way we are approaching our patients in interventional cardiology, whether in coronary advances or a completely new era of structural advances, needs to be discussed. Electrophysiology, with its very fancy, colorful tools, has grown by leaps and bounds. It has also helped us understand ECGs better. We can share ECGs with our friends. And here I would really make a point, which I had not included as an outline of these game changers, is the advent of use of telemedicine in the way that we practice our day-to-day practice. We can share EKGs, we can share electrograms, we can discuss with our colleagues, and all with one simple, inexpensive WhatsApp message, which goes from place A to anywhere on planet Earth. So I think the advent of conduction system pacing and physiological pacing has also improved many of the bad effects of pacing which have been seen before. So this is something which really needs to be discussed, whether we do 3D mapping, whether we're doing radiation therapy for intractable ventricular arrhythmias, or we are doing physiological pacing. This is something which is fancy. We also have devices which will prevent a left atrial appendage being occluded, will prevent embolic event or cardioembolic events in atrial fibrillation. But one of the greatest developments in the last 5 years, and the next decade is surely going to be a decade which is related to the treatment of heart failure. We have, after the paradigm heart failure study, our understanding that we need more agents, the establishment of beta blockers, moving from beta blockers to ARNI and ACE inhibition, and then moving on to mineralocorticoid receptor antagonists, and now with the advent of SGLT2 inhibition, which actually started as a treatment for diabetes, but has now become a kind of we call this the foundational 4 therapies for heart failure. But not to worry, we are not only leaving it at foundational 4. We have new drugs which are knocking, the new kids are knocking on the door. We have vericiguat for worsening heart failure. We have omecamtiv, which is actually one of the first positive inotropic agents in whom we expect that we are going to have positive results. But not just this, our way we understand and segregate our patients, maybe in a few years, we will not be using the terms like heart failure, preserved ejection fraction or reduced ejection fraction. Because many of these treatments are going to be agnostic to the ejection fraction. They are going to be more determined on the presentation and the profiling of the heart failure. So we need to do a better phenomapping. We need to have a better etiological understanding. And really, in aiding this are improvements in echocardiography, improvements in cardiac imaging by CT and MRI, and our understanding of various biomarkers. Now, 10 years ago, these biomarkers, I used to lecture on biomarkers, and they were not really parts of daily or day-to-day practices. But today, everybody knows about troponin. Everybody is doing an NT-proBNP. Yes, lesser people than required are doing soluble ST2, but a lot of people are doing procalcitonin to rule out infections. Galectin-3 as a biomarker to look for fibrogenesis is something, and cystatin C for nephrological involvement can also be studied. But apart from these evaluation, we have, like I said, better devices. We moved to conduction system pacing, and therefore we have definitely advantages in using hot CRT and lot CRT, which is his bundle pacing, and left bundle pacing, assisted CRT, which will further improve the qualitative benefit that heart failure pacing can give our patients. We also know that ventricular assist devices have become smaller profile and less expensive. But the revolution which happened this year was the about 60-day survival of Mr. David Bennett, who was the first patient who actually survived more than a week, who had a xenotransplant. A pig which was used using CRISPR technology was genetically modified, and with many modifications, this gene-edited pig, which had the PERVs removed from its subsequent clonal expansion, the heart of that was implanted in a refractory heart failure, no options patient, and unfortunately he succumbed to a cytomegalovirus infection, or possibly to a cytomegalovirus infection. But he lasted about 2 months. So whether or not that's the way to go, well, that is time will tell. There are some ethical issues concerning that, which we can discuss, but it gives us a great hope and a great opportunity to look at that. COVID itself has been a game changer. Many of us had to rely on telemedicine, telecardiology, doing risk stratification, helping blood pressures, which are all being recorded in domiciliary conditions, looking at sugars, looking at clinical presentations, and looking at this small computer screen and managing ourselves. We also know that COVID produced a myriad of cardiovascular complications. Myocarditis, if you look at the MRI evidence, it was in a large percentage of cases. Obviously, people did not get MRIs done, but for competitive athletes and sportsmen, when these were done, we had some data. Autonomic dysfunction, fatigue as a manifestation. So, and there were great challenges. But with great things also come disclaimers, which we must not forget. This is also the time that we had big data being actually looked at very, very carefully. We had the Surgisphere fiasco, where the distinguished professor of the William Harvey Distinguished Professor of Medicine and Cardiology in Harvard, who actually made 2 presentations, one in New England Journal and one in Lancet, had to have them retracted because that big data had not been collected appropriately. So there is a great opportunity for us to understand, to be part of this progress, to participate in this progress, to also use big words like artificial intelligence, to use augmented and virtual reality. We all know that we can do a 3D printing before a complex procedure, and to actually test out your device before you actually use it. So all this looks super, super exciting. And although we are on the wrong side of 60, I can tell you that we have the excitement of a teenager on his first date out when we study cardiology. So with that, that is the outline. And if Nilesh permits me, we will discuss this in a series of developments and take this forward. Because we all understand that survival is the survival of the fittest in Darwinian hypothesis. And Darwin said only the fit survive. But really, it is our adaptability to change. It's our ability to stay awake, to adjust to new ideas, to remain vigilant, and to face the challenge of change, and to be so that we remain relevant, we remain important enough to be able to contribute to our patients. A very complex slide. I made it a few years ago. I keep using it every now and then. It gives me a snapshot of historical landmarks in how we've reached today in cardiology. So the first one here is Reverend Stephen Hales, for the first time in the 1700s, measuring the blood pressure of a horse by putting a glass manometer into the horse carotid artery. This was possibly the first intervention. Laennec took away the joy. Imagine the days gone past and all so-called cardiovascular physicians had actually to put their ears to the backs or chests of charming young ladies to hear their heart sounds. But he took it away by introducing the stethoscope. And then William Einthoven did something brilliant, because he understood with efforts of Johannes Boscha and his famous dog called Jimmy, on whom a large number of these experiments were done, that he could actually make an EKG. This is the first ECG machine. Today, an ECG machine comes as a patch. So how things have changed. But in the words of Johannes Boscha, even in the 1890s, and when Alexander Graham Bell actually introduced the telephone, he felt that this ECG could be transmitted across cables, and he felt it could be transmitted across the Atlantic to the US for interpretation, for example. Werner Forssmann, in trying to impress his nurse, Ditzen, asking her out for dinner, actually took her down to the X-ray department. And it all started because this gentleman here introduced, he actually introduced the X-ray. And once Werner Forssmann took Ditzen down to the cath lab, to the X-ray department, he actually passed this red rubber tube into the right heart. And this was in 1929. And this was probably the first cardiac catheterization known to man. Three very exciting things happened with Ditzen agreed to go out for dinner with him. He got sacked from, he was a urology trainee, he got sacked from the Department of Urology, and he won the Nobel Prize 24 years later, for which his comment was, "I must be the least intelligent person to ever win the Nobel Prize." Well, at the same time, lots of other things had happened. 1700s, I actually went the wrong way. So we had William Withering, who introduced the properties of pink foxglove. Now, if you put your hand into this, it looks like a glove which belongs to a fox. And therefore, this was the first treatment for dropsy, and it was Lanata purpurea. It is pink, and we can understand that. I've already showed you that the X-rays were introduced, and thereafter we had Nikolai Anichkov, who in 1913s, he was the Surgeon General of the Russian army, and he thought that why do people's arteries get clogged? So he took rabbits and fed them a whole lot of egg yellow till their arteries got choked when he harvested them. And he started, which even till today is called the lipid hypothesis. I put two other photographs here. One is, of course, Mason Sones. Mason Sones was a maverick. He was in Alabama, and he used to run the cath lab. He used to apparently curse and smoke like a sailor. Sailors get bad names. He apparently had a forceps, which was placed on his cath table, with which a cigarette would used to be put in his mouth. And those days, they did not have the cine angiography, which we have today. They had cut film changers, which used to rapidly change. And by accident, one of his catheters flipped into the right coronary artery. And at that time, he recorded the X-ray. And that X-ray was the first coronary angiogram. And this was done by Mason Sones and Emory. And as he said this, he said, "Oops, I just revolutionized cardiology." So with that, we moved to a new era of coronary for initially diagnostic. And later, this gentleman here, Grunzig, changed it all, funded by a cardiac surgeon by the name of Ek Senning. He developed a very simple balloon technology with a dream to be able to do what we do today, with this, which is a percutaneous treatment of an atherosclerotic blockage. So we moved a long way, and a few years ago, Professor Eugene Grunwald actually put forth this entire development. We also did not give credence here to some cardiac surgeons. We had the development of open heart surgery by Gibbon using the help of IBM. The heart-lung machine was developed. We had drugs which were developed. Favaloro did the first bypass surgery. The coronary care unit was developed by Julian. And then we moved forward. And by about the 80s, we had Miroslav Mirovsky developing actually the ICD, which is a great development. And then we realized that after we lost Grunzig in a tragic air crash in 1982, but we moved further and showed that primary PCI was superior to thrombolysis in acute MI. And we moved further thereafter to the current times. So it's been a long journey. It's not been an easy journey. It's been a journey of roller coaster rides. Everything is not always rewarded. There are times that you feel that commercial interests have taken over academic or clinical interests, because there are always naysayers. There are always skeptics. There are always those who actually doubt the fantastic developments which have happened either in our backyard, or in the clinical development, or in our clinical understanding, or by our technicians, engineers, who probably we don't even discuss, whose names we don't discuss. For example, we all know Ranjan's name, and we all know Ranjan's wife's name was Maria, because that X-ray which I had shown was the X-ray of her ring finger. But we don't know the technicians who are behind this development, the engineers who are behind this development. Today, there is a lot of analog development in biopharmacy and how we can deliver these drugs. So it is a very exciting period. Let's move to another timeline of atherosclerotic cardiovascular disease. Now, is actually atherosclerotic cardiovascular disease new? Because we've had in recent times, we've had these celebrities who unfortunately had not very good outcomes with having acute coronary events. We lost a couple of cine stars. One of them actually reported in the middle of the night that he had some dyspepsia, and well, he was told to have some nimbu pani, pudinara, etc. The other one was gymming away and continued to gym away, while the third one was running a concert. And when he was running a concert, the security staff, even when he was not well, made him walk to the car and took him to his hotel first. And unfortunately, by the time he was brought to the ER, he could not be salvaged. But this is not a new problem. This problem has been known in the mummies in Egypt, in people who have been discovered, who are actually bodies which have been discovered in the Alps, which are actually mummified for over 5,000 years. Their X-rays have shown evidence of vascular calcification. And it was in 1772 that William Heberden, for the first time, described the angina pectoris. Yeah, I mean, his classic description even stands today. On a cold wintry afternoon, a heavy-set smoker carrying a heavy load after a heavy meal climbs up a hill. After some time, he appreciates a discomfort in his chest. He cannot localize it. It is diffuse. The pressure intensifies over a period of time. Over some time, he starts to have little shortened. This is a disagreeable sensation, which leads to shortness of breath. He has a few cold sweats till he puts his load down and he sits down for breath. And in 2 to 5 minutes, this goes over. This is a classic description of stable effort angina, which we can use even today. Over the next few years, we understood that this could be linked to atherosclerosis, and then atherosclerosis could be linked to myocardial infarctions. The last textbook of pathology by William Boyd, which was there when I was an undergraduate, actually said we do not know what comes first, whether it is an occlusion in the coronaries or it is a myocardial infarction. But really, all this happened because we at the same time had Virchow, who described inflammation, cell proliferation, and we have Windaus, who found cholesterol in atheroma. I already told you that Nikolai Anichkov actually, he produced atheroma in rabbits by cholesterol feeding. And then it was led to some of the biochemists who actually could ultracentrifuge the lipoproteins by Goffman. And all this moved on till actually Roosevelt happened. Because when Roosevelt succumbed to hypertension, a great effort was launched to kind of understand what are the way we can prevent disease. So the NIH was formed, and a village called Framingham outside of New York was adopted to identify the factors of disease. And this were Paul Dudley White, and they all worked very hard to try and kind of identify this. Because at the same time, a lot of other exciting things happened that by about 65, 68, Rene Favaloro, unfortunately, many years later, because of what happened in Argentina, this brilliant mind and with brilliant hands was forced to end his own life. But in 68, he started coronary artery bypass grafting surgery. And thereafter, in 73, a unique event happened. Goldstein and Brown, and these are Goldstein and Brown, they actually identified the LDL receptor. So when we started with cholesterol, we moved, cholesterol is a cyclopentanoperhydrophenanthrene ring. We moved from there to our different lipoproteins, which we had as high density lipoprotein, low density lipoprotein, very low density lipoprotein, remnants, and we had intermediate density lipoproteins which could come in the middle. But thereafter also, what we realized that these lipoproteins had to have an apo-moiety, an apolipoprotein moiety. And at that stage, it was also realized that the receptor hypothesis took birth, which meant that even if you tried to reduce the LDL cholesterol or to reduce the cholesterol, see, for many years, we went through a whole lot of trials and tribulations because we thought that only those who overeat, who were affluent, had a high cholesterol. But that was not true because only 1/4 to 1/3 of the cholesterol comes from our diet. 2/3 is what the body synthesizes. So, and once your cholesterol is high, why does it remain high? Because this LDL cholesterol also has a pathway, and that pathway is related to the LDL receptor. So Goldstein and Brown elucidated the structure of the LDL receptor and the fact that this LDL receptor can internalize, it can increase its numbers or decrease its number. It can be upregulated or downregulated. And this LDL receptor has a breakdown cycle. Today, that breakdown cycle has been utilized very, very smartly by a few companies who have actually brought inhibitors of the major enzyme which breaks down the LDL receptor. But before that, what happened was this gentleman called Akiro Endo. He discovered the value of statins, and he discovered the fact that if you had these statins, which are there even in nature, so red yeast rice or lal pohe contains actually the yeast itself makes an HMG coenzyme A reductase inhibitor, and these HMG coenzyme A reductase inhibition is or the reductase is a rate limiting step in cholesterol biosynthesis. So once you control it with statins and all the other previous drugs, cholestyramine, bile acids, everything had failed. But statins worked because this was a rate limiting step. And once they worked, they did very well for some time, till such time, and their clinical efficacy was established by a large number of sequential trials, which were done in primary prevention, secondary prevention, which were done in acute coronary syndrome, which clearly identified the value of statins. But we wanted something better because there were still unmet needs. And because there were unmet needs, well, we moved further. And what did we do at that stage? Because we realized this receptor, this is how it gets internalized. This receptor itself breaks down with an enzyme called PCSK9. So this PCSK9 could actually be inhibited, and we had monoclonal antibodies which were used. We have evolocumab and aliricumab, which are available, and these drugs could inhibit the PCSK9, thus causing more receptor, thus causing less LDL to be present in the blood. And the similar thing now has been used by a small interfering RNA, and all this is modern technology. And already inclisiran, or Leqvio, as it is called, has been approved in the UK. It is getting FDA approved, and once it gets CMS approval in the US, well, maybe in about 6 to 8 months, we are likely to get inclisiran here. What is the advantage? Oh, the advantage is that although evolocumab will require 2 injections in a month, statins have to be taken daily. We know that evolocumab will have 2 injections in a month. Inclisiran will have 2 injections in a year. And, well, there is something more happening, which we will discuss later, that maybe today, using CRISPR technology, a new company has started a new drug called VERVE-101, and that will require 1 LDL, 1 injection, VERVE-101. The first patient has been recruited in a trial in New Zealand, and that will lower the LDL cholesterol by 70% for a lifetime. We also have a lot of other drugs. We realized that the absorption in the gut leads to something wherein you have a Niemann-Pick type C receptor being used. So ezetimibe got established. Then we looked at fish oils, because for a long time we were looking at omega-3, omega-6, and we were looking at fish oils, but we realized that fish oils contain EPA and DHA. And whereas EPA was good, DHA was not so good. And therefore, we went ahead to purify the EPA and to synthesize it directly. And this synthesized IPE, or icosapent ethyl, also has significant reduction in triglycerides and significant clinical benefit. We have outcome data today from PCSK9 inhibitors. We have outcome data from statins. We have outcome data from combination of statins and ezetimibe, which is the Niemann-Pick type C inhibitor. We have some outcome data from use with icosapent ethyl. And we have new drugs which we are working on, because those drugs will cause rate-limiting step changes without acting on the muscles, which was one of the problems with statins. So you have bempedoic acid, which is making its way. And we are addressing other targets. The STENO2 trial showed us that 70% of risk reduction in diabetics happens by non-glycemic pathways, thus making sure that the importance of lipids at the core of atherosclerotic cardiovascular disease remains. And today we have GLP-1 receptor agonists, which also have an anti-atherogenic modality. And also there were some very, very expensive drugs. The CANTOS trial tested something called canakinumab, and which was an anti-inflammatory agent, but very expensive. But this particular group in Harvard, led by Zibby and Brown, they actually felt that by using an anti-inflammatory drug, they would actually be able to decrease the incidence of atherosclerotic cardiovascular disease, as well as many malignancies. So, but what has it showed us? It has showed us that we need to act early, because the time for prevention is early. Once the disease gets established, it is actually a little difficult to really act. And there has to be accurate identification of patients who are at risk for future cardiovascular events. For that, we all go back to the standard cartoon, because we know that we have non-modifiable risk factors and there are modifiable risk factors. Age, well, ladies do get younger every birthday, but otherwise, age is an immutable risk factor, which increasing age gives us a little higher risk. The male gender is at higher risk. The female gender in the reproductive age group, those who do not smoke, those who are not hypertensive, those who are not diabetic, those who do not take oral contraception, and those who don't have a very strong family history in reproductive age group are seemingly protected. But they have other novel issues which can happen to them. For example, they can still get spontaneous coronary artery dissection, which are not related to atherosclerotic. Well, genetics is important, and today we have not just genome-wide associations, we have polygenic genetic risk scores which are being evolved to understanding. Lipoprotein small a, why we have included in this slide is on this side, because till now we don't have drugs which we can alter the lipoprotein little a, but we are hopeful that maybe by the time we conclude this series of advances, we'll be able to present to you the data from some of the agents. The agents have already been shown to decrease, at least for 6 months, use of pelacarsen has been shown to decrease lipoprotein little a. But till today, the recommendations are measure lipoprotein little a at least once in the lifetime of a patient, because it is felt that you can't change it. So, and because it is a risk amplifier for both atherogenesis as well as thrombogenesis, it is something which is important. But what we can change, we discussed lipids. Smoking is very important. The current AHA simple 7 has become a life simple 8, which includes psychosocial stresses as well as sleep. I think sleep is an underrated risk factor which needs to be stressed on more. Diabetes, we all know our targets for control in diabetes are going to be to achieve an HbA1c around 7, to have no hypoglycemia, no weight gain, and to also concurrently look at lipids and blood pressure, and to stop smoking or using tobacco in any form. Well, our antihypertensive treatments have improved, and we today have anti-inflammatory measures. Because why we are discussing adiposity and obesity is because abdominal adiposity leads to insulin resistance. And once there is insulin resistance, there will be a hyperinsulinemia to combat the insulin resistance. And insulin itself may be vascular toxic. And this will contribute to what is called the metabolic syndrome, which has hyperglycemia, hypertension, dyslipidemia, and it can have other miscellaneous risk factors. A similar thing would be in operation in polycystic ovarian syndrome, and can lead to not just diabetes with beta cell exhaustion. We are likely to get diabetes, Franz's octet. We have at least 8 levels at which diabetes happens. You can get cardiovascular disease, and all of them can get complicated because central obesity with insulin resistance, and we are actually continuing to study the patterns of obesity, whether it is visceral, whether it is abdominal gluteal, whether it is subcutaneous, and we look at various things in this because this insulin resistance, we all know that food and exercise do make a man look like, say, Ranveer Singh in his recent shoot, but notwithstanding, today we are going to be able to pharmaceutically not just use diet and exercise, which will continue to be the most important thing in our understanding, because the entire definitions of metabolic syndrome did change over a period of time. Today, we also understand that this contributes to a vulnerable patient and inflammation, and also go on to see something like non-alcoholic fatty liver disease, which will be part of this syndrome, which is a marker of high cardiovascular risk. Not only that, it has replaced alcohol and hepatitis as the leading etiology for liver transplants in the world. So there is a distinct cardiometabolic connection, which because it can lead to fibrosis, and fat accumulation. There is an increased hepatic glycogen content, and yet we need to manage this very well. A very important area, one of the new developments in cardiology has been two new branches of cardiology, cardio-oncology and cardio-obstetrics. Now, what is a cardiologist doing with obstetrics? When I was an undergraduate, the only obstetrics I was supposed to know was having a rheumatic heart disease with right mitral stenosis who comes in labor. And this was a question asked in medicine exams and in gynae exams, and we had to answer this. But adverse pregnancy outcomes, including gestational hypertension, preeclampsia, gestational diabetes, fetal growth restriction, all have insulin resistance and can contribute to cardiovascular risk. So we have changed our concept of coronary artery disease from 1980 to currently. We were initially all lesion focused, but today we are patient focused. Maybe in a few years, we ought to be community focused. And we moved from defining vulnerable plaques to now defining vulnerable patients. We have understood that inflammation is also a key driver. Lipidology is very important. We have moved from just pursuing relentlessly coronary revascularization to now the paradigm has shifted to early detection and prevention. So if we were to look at a simple thing like a CT angiogram, and we are going to discuss this later, but allow me to tell you this here. A CT angiogram has excellent negative predictive accuracy. If your calcium score is 0 and there is no plaque burden, it gives you a clean bill of health for the next 5 to 8 years. At the same time, it cannot look through metal, it cannot look through calcium. And because it cannot look through that, it is something which needs to be carefully observed. But we must understand a few odd things which happen. When we use statins, unfortunately, the calcium score increases, but this calcium may actually be protective. So it is sometimes counterintuitive to understand this concept. At the same time, when we have a calcium score which is positive and some plaque burden, even if it is subcritical, less than 50%, because the other problem with CT angiogram is it has a high standard deviation of error. So even if it is less than 50% and we deem it less critical, it is a time for us to institute effective and strong lipid-lowering therapy to be able to alter the cardiometabolic milieu to decrease the risk of disease. Because Professor Eugene Grunwald, in an editorial, actually showed that it is not just important to decrease the cholesterol, but it is important to decrease the cholesterol for significant length of time. Taking the immortal timeline concept, he said, if you want to live to 100, and may God bless him, he's in his late 90s now, he's mentally very alert. He said that you should have a threshold of 7 LDLC gram years. And he actually said that if you can change this and decrease your cholesterol for any length of time and significantly decrease it, well, then you may not get atherosclerotic cardiovascular disease. Just a quick recap. We have covered some of this, but the various drugs which are available. Now, this is the pathway to form cholesterol. Glucose, acetyl coenzyme A, HMG coenzyme A, cholesterol. And statins act here. They are HMG coenzyme A reductase inhibitors. But today we have other drugs, which are like bempedoic acid, which is an oral agent. It is now introduced in India. We still don't have outcome data, so I'm giving a disclaimer, but it is an ATP citrate lyase inhibitor. It decreases the production of pyruvate to acetyl-CoA. And because this step does not happen in the muscles, it does not have muscular effect. Of course, we have drugs which act on the LDL receptor. We have PCSK9 inhibitors, which are eloducumab, evolocumab, and we have inclisiran, which blocks the PCSK9 translation. We have drugs which act on the intestinal lumen, which act on the Niemann-Pick type C receptors, which are ezetimibe. We still can have some newer agents which we are looking at, which are monoclonal antibodies against something called angiopoietin-3. Because we understand that the ApoB containing lipoprotein family is not just the LDL, it is also the lipoprotein small a. And the lipoprotein little a, as I mentioned, was actually a risk amplifier and also has triglyceride-rich lipoproteins, which include the remnants. And so we have many new molecular methods. So you can use the CRISPR technology, which can use gene and base editing. And I discussed with you just now that Verve 101 is the simple use of CRISPR technology. One injection, 70% reduction lifetime. Early days yet. First 40 patient trial just started. First patient recruited about a week or 10 days ago. More to follow. But we have good data, including outcome data from PCSK9 inhibitors. We have good data from small interfering RNA, inclisiran. We are getting data. We are getting there with some outcome data this year for all of this. So all this will be using modern gimmicks and tools and toys and science, which are gene editing, base editing, antisense, oligonucleotides, antibodies, small molecules, and all this can actually have different ways. We used to be very concerned about triglycerides. We all understand that triglycerides are probably a surrogate risk factor, but more associated with fatty liver disease. But we today have drugs which act on apolipoprotein C3. We have volanorson. We have angiopoietin receptors, which are evanucumab, volanorson, which act here. And we have other drugs like IPE, which I had discussed. So we have a huge amount of lipidology options. This is a growing field. This is an exciting field. But at the bedrock of it remains lifestyle modifications. We have to use statins. We have to be aware of muscle symptoms. Yes, aggressive exercise at this time should be avoided to avoid muscle symptoms. We have only learned that if you have low vitamin D, you probably get a little more muscle symptoms, but giving more vitamin D doesn't always take it away. I do not know the role of coenzyme Q10. Some people respond well. Well, those who do, I don't see it does any harm. Ezetimibe can be used in combination, which so with statins, we have a rule of 6. Even the smallest dose is effective, but we know that the ACC gave guidelines about a moderate intensity, high intensity, and low intensity. So even the smallest dose is effective. Doubling the dose leads to an additional LDL reduction by 6%. If you add ezetimibe, it kind of triples the LDL reduction. So bempedoic acid is already available with us. Some patients have shown good response. Well, I always measure lipoprotein small a at least once in the lifetime of a patient because I know how aggressive I have to be with LDL reduction, because lipoprotein little a is like an amplifier. So if you remember in school assemblies where they would say mic testing 1, 2, 3, and it would go amplified. So if we can't change lipoprotein little a right now, we can at least modify the LDL. So less of it to get amplified. Well, we are looking at some drugs like pelacarsen. We are looking at high dose icosapent ethyl. And then we are looking at, in some patients, we have unfortunate families of homozygous hypercholesterolemia who have many people who have succumbed not only to aggressive malignant coronary artery disease, severe aortic stenosis, dilated cardiomyopathies, and so on and so forth. We have used other drugs and we have used mipomersen, and we have actually taken a few of them through lipoprotein apheresis. So if you look at it, it is not just lipids. So you need to, for lipids, you need to do the residual cholesterol risk. You also need to decrease the residual inflammatory risk. I'm not very sure if in India HSCRP is an adequate biomarker because it's been validated in Western populations. What its role in India, wherein you have a lot of inflammations, a lot of viral infections, a lot of pollutions, a lot of obesity and metabolic syndrome. What it will do to that, I'm not really sure. And many of these agents like statins have also with them anti-inflammatory action. And then you have to also decrease the thrombotic risk. And this really the COMPASS data showed us that by dual pathway inhibition, we can actually reduce the thrombotic risk. We can look at residual triglyceride risk, like I said, IPE, and in some cases the fibrates. And we are hopeful that the holy grail is that we will have successful agents to control lipoprotein little a, but if it is more than 50, control the LDL even further. and then look at fasting plasma glucose. So I'm going to stop here because it's already been a fair amount of time, and I would really welcome any questions. The next time when Nilesh does permit me, we will move on from here and move to interventional cardiology. Is that okay, Nilesh?
Yes, sir. Completely fine. Completely fine. In fact, we do have quite a good viewership even now, but I suggest that we do stop at this time because it would get a bit too long, more than an hour. Yeah. And the way we'll have it, sir, is I do not have any questions right now. I think we are all just absorbing everything that you're saying. And what we'll do is we will have the second part of this particular thing, emerging technologies, on 14th of August. That's a Sunday. We'll have it at the same time. If you have the time for us, sir, then.
Yeah, sure. Anytime for you.
Thank you, sir. So we'll have this same session, the second part on emerging technology, starting with interventional cardiology on the 14th of August, Sunday morning, 11 a.m. All the people who have already registered for this will get invites from me. Plus, we'll be doing a new round of enrollments for the second part of it, sir. No questions right now, sir, but thanks a lot for your time. Thanks a lot for your time. I thank the audience for being here. And please make a list of all the questions. We'll definitely ask him all our questions on the second part on 14th of August morning.
My email is available. If anybody wants to call me or email me, they can send their questions and I can call them back personally and answer.
Dr. Anil Dhall at gmail.com.
That's correct.
Correct. So you could email him anytime, or you could email me. Everybody has my email ID. Please email me and I'll connect you to Dr. Dhall. And see you for the second part on 14th August. Jai Hind.
Jai Hind.